Hi, all. I wanted to finish our Chapter 12 Acute Care and Emergency Procedures with you because I do know this content will be on your exam, which is next Wednesday. We left off with talking about primary survey, which with the primary survey, we're making sure that our patient has their ABCs, airway, breathing, circulation. We want to make sure that they don't have any type of severe bleeding and that they're not going into shock. Once all of those are cleared, we can safely move them to the sideline to be able to do a more thorough evaluation. And in that thorough evaluation is going to be the secondary survey. So we had discussed already about checking their level of consciousness. Remember AVPU, alert, verbal, painful, and unresponsive. So that was the level of consciousness. We're evaluating their pulse, respiration, blood pressure, temperature, skin color, and their pupils. So we're going to get a little bit into that right now. So with the pulse, when we're checking for a patient to have a pulse, we want to make sure that we're checking with our index and middle finger and not our thumb. Our thumb actually has its own pulse and might be accidentally, we might accidentally feel that and assume that it's the patient's pulse when in fact it's ours and maybe that patient does not have a pulse. So the pulse is a direct extension of the heart function, and for an adult it's usually going to be 60 to 80 beats per minute, and for a child it's going to be 80 to 100 beats per minute. For an infant it's about 140 beats per minute. So if there was a question in the exam that says, what is a normal pulse for a human? Your answer should be 60 to 100. The pulse is going to tell us a lot of things, and we can either check it with, obviously, like I said, with our two fingers at the carotid. So either side of the carotid. You can also take it on the radial pulse, which is on the radial side or the thumb side. Potentially you can take the dorsal pedal pulse or the anterior tibial pulse, and that we will go over when we get into lower extremity. The pulse can tell you a lot of things depending on what kind it is. So if it's rapid and strong, we're worried about that either they've been frightened or that they have some type of heat illness. If it is strong and slow, we're worried about stroke and or skull fracture. And obviously no pulse, we're worried, it's imminent death. So that's when we would end up having to perform CPR. Moving on to respiration. Normal respiration for an adult is 12 to 20 breaths per minute. So if you think about that, that really only is, one breath every 5 seconds. Okay. So I do want to note our patient population is usually or stereotypically going to be student athletes. And with that, take into consideration what their activity level was. Were they just running around and participating in their sport? It's going to be normal for everything to be elevated as far as pulse, respiration, blood pressure. We will expect it to be on the higher end, but when you recheck it in 5 to 10 minutes, it should be going down. If it's not going down, those are the indications that we talked about before with pulse. And with respiration, if they have really shallow breathing, we're worried about shock. If they have kind of frothy with blood, there's some type of chest injury. And irregular gasping, there could be cardiac compromise. So one thing when we're evaluating the respiration is seeing if it's their chest is clearly rising and falling, and if it's an even kind of flow. If you guys have ever been out of breath running or whatever the case may be, kind of what it feels like to kind of gasp for breath. Anybody who has been around an asthmatic, usually you will hear the kind of wheezing, but it's more so on the exhalation. Okay. Blood pressure. Blood pressure we measure with a sphygmanometer and a stethoscope. Okay, so the sphygmanometer is going basically blood pressure cuff. And what that is assessing is your blood pressure. So systolic blood pressure is going to be the top number. Diastolic is going to be the low number. So usually I would have my whiteboard and write sky over die, sky meaning above, die, down in the ground or below. So that will kind of help determine when, if there's a specific question, what does this number for systolic mean? Make sure you know the difference between systolic and diastolic. Okay. Systolic is evaluating the pressure created by the ventricle of the heart in the heart contraction, and kind of reviewing anatomy. For a heart, it's not normally like this, but how I explain it is a heart would be kind of like this, and that's how you can kind of remember what the chambers are. The top one is kind of like an A, and then the bottom one is V ventricle, A arterial. The diastolic number is going to be the residual pressure between beats. Okay, so what we do is and we'll go into this when we talk about our vital signs lab, but we would put the blood pressure cuff around the distal portion of the upper arm. Okay, so I'll stand up a little bit, but the distal portion, so it's going to be right down here. Again, we would be in anatomical position, and on the BP cuff, there's going to be a line that says, artery goes here. So make sure when you put the Velcro around your patient's arm that line is on the anterior surface. That's because that's what's going to be able to measure. Okay, so we want to place the cuff on. We don't want it on so tight that it's already occluding or causing, them to lose feeling, but we don't want it so loose that it's just falling right off. Okay, so there are two different ways to take blood pressure, and we'll go more into this when we go into our lab, but usually how I teach it is we will inflate the cuff up to about 200 millimeters of mercury, which is what it's recorded in, and we will slowly deflate the cuff to, for about 2 millimeters per second. So it's just slowly going down, and I will have a video when we get to the lab portion. So when it's slowly going down, what we're doing and listening for with the stethoscope's going to be in our ears, and the angle of the stethoscope is going to be up kind of like mountains, and you'll have it in your ears, but we're listening for what that number is on the very first heartbeat, and you'll take a mental note of it. And then you're going to keep hearing beats. I don't want you counting how many beats because I don't really care how many beats. What I'm looking for is for you to listen for what that number is on the very last beat that you've heard. Okay, so textbook blood pressure is going to be 120/80 millimeters of mercury. Very rarely do we get anybody who has exactly that. When you're doing the manual blood pressure, which is what we're going to have to do for our vital sign, is, pump it up manually. There are digital ones where you wrap the cuff on, you press the button, and it automatically reads. Those are great. They're usually very bulky. You run the risk of potentially having a battery go out or whatever the case may be. So that's why we always take a manual blood pressure. It's usually much more accurate, and it takes practice. So that's something that we're going to have to do. But we are listening for that first heartbeat, what that number is, and then that last heartbeat, what that number is. Okay. Temperature. So you guys hopefully are familiar with temperature, especially, unfortunately we're in a pandemic, and some places that you go to require you to get your temperature taken. There are, and probably what you're familiar with right now is the infrared temperature takers, where it kind of looks like a gun where you're pointing it at the temporal and assessing via infrared because it's touchless. And that's one of the issues that we're worried about in this pandemic. There are other ways to take a temperature, one of which is under the tongue in the mouth. So say This is the thermometer, and the pen cap is what's going to be the reading. You're going to place it, have them lift up their tongue, place it underneath their tongue, and have them close their mouth. Usually, some are fairly quickly. Some of the older ones, or if the batteries are dying, might take a little bit longer. But we measure it, and normal for an adult or anybody is 98.6 degrees Fahrenheit. Okay. So that's how you take it under the mouth. Under the armpit, so if you have infants, they're not necessarily going to allow you, and they're not going to necessarily keep it underneath their tongue. So we would put it under their armpit. I would caution, again, if this is my thermometer and we take it in the armpit, we make sure that it goes under the armpit and closes. If I have it, I don't know if you can see, if I have it out here, you're just taking the room temperature. So we need to make sure that it actually is underneath and in the armpit. There are temporal scanners where it's great, especially for infants or little kids. You don't even have to wake them up. You can kind of just scan across their head. And then there actually is a rectal thermometer, which is actually the gold standard and the best way to get an accurate reading on core body temperature. And really the only time that I would be taking a rectal thermometer would be if the patient went unconscious and we don't know what the circumstances are and we need to get that core body temperature. I know it sounds gross. I've never had to do it. We've had to practice, but and people used to do it with their infants because that used to be what you used to do, and some still do, but on that one it would be more of the mercury thermometers where they would have to go in rectally and take the temperature. Same concept. It's not even as big as what you would think. It's kind of like, I don't have anything, a power cord or what you charge your phone with, maybe like the length or circumference of this hair tie. And we're taught on how to properly drape and all this other stuff. And there actually have been people, athletic trainers and physicians, who have had to do a rectal thermometer kind of in the middle of the stands, when something's happened. So there are ways to do where you're not just dropping trowel, bend over. They would be unconscious. Okay. So digital oral thermometers are usually reasonably accurate. The reason nowadays that people are using the infrared, which are not really that accurate but give us a better indication, is because it's touchless because of this virus. So the CDC standards is if you have a temperature over 100.4, you get sent home and you can't go, whether it's to school or for a job or whatever the case may be. And the reason it's that low is because the infrared ones are not that accurate, and they don't, it's showing that there is a slight temperature. So either they quarantine and later get a test, or make sure they don't have any other signs and symptoms. There's a whole bunch of different reasons that your temperature could be elevated. Okay. Temperature changes can be a result of disease, cold exposure, pain, fear, or nervousness. I know yesterday I went to take my son into the dentist, and they had to take our temperature, and mine was like 94 or 95, and she had to take it a couple of times. I was like, well, I just was in my car with the air conditioning blowing, and so even an ambient temperature like that can affect the infrared. Okay. Lower temperatures are often accompanied by chills, teeth chattering, blue lips, goosebumps, and pale skin, meaning obviously they have some type of cold. And we will get into heat injuries and cold injuries in another lecture. Skin color. So skin color can be an indicator of health. Hopefully you guys remember from the beginning of this lecture when we were talking about hepatitis B and hepatitis C, and I talked specifically about yellowing or jaundice, and that is going to be indicative of, that type of failure. The other skin colors that we're looking for are red, white, blue. Blue is going to indicate cyanotic. Cyanotic is the medical terminology for lack of oxygen. Okay, so usually there's an airway obstruction or they're not getting enough air in. I know when my kids were little and like little babies, they would cry and their lips would start turning blue because they wouldn't even like breathe in. And I would have to kind of blow in their face to kind of remind them to breathe in. I probably didn't have to, but it just scared the crap out of me. White, it means that that person is not getting enough blood perfused to where it needs to be. So there's insufficient circulation, could be frightened, heat exhaustion, potentially insulin shock. And then red, we're worried about elevated temperature. So think of heat illness, heat stroke, and high blood pressure. Also with red, it could potentially indicate that a fever, that person potentially has a fever, but not always. And for patients that are darker pigmented, their skin is not necessarily going to be as responsive. And I would say, look on the nail beds of what the coloring is. You can also look on the inside of their lips. And then also with jaundice, the conjunctiva of the eye, the white part of the eye, will have kind of like a yellowish tint. When a person is in shock, the skin around the mouth and nose could be more of a grayish color. So that's something that we're worried about. So all of these different colors are going to give us a good indication of what's going on with their overall health. Another vital sign can be pupils. Okay, and you will hear me talk about PEARL, P-E-A-R-L. Okay, so that is an acronym and it stands for pupils are equal and reactive to light. So what I'm talking about that is we are trying to get or trying to see the reaction that the pupils, so the darker part of the eye, has to light. We have usually these pen lights that will help us. Seems like everybody has cell phones. There's a little flashlight app on it, and I've used it before on the sidelines when I have them, stare directly at me. I don't want you to move your eyes, and I have my phone away from them, and then I bring it in towards their eye and back out. What I'm doing is when that light hits their eye or their pupil, normally their eye is going to be right here at B. When the light shines, the pupil is going to constrict and get smaller. And then when you move it away, it should get bigger. Okay. Say you don't have your phone. Say you don't have a light. Kind of good old fashioned way. And whether you're outside or in the gym, unless it's dark out, but if it's dark out, you're usually going to have stadium lights. You can do something as simple as covering their eye with your hand for a couple of seconds and wait, and then remove it. When you remove it, it should immediately constrict and then start going back. Okay. And again, we want to check bilateral. Make sure you're checking both. So I'm not worried too much about the circumference of this. I'm worried about, is it reacting? And is the right side reacting to the left side at the same amount? Okay. There's times where I've had patients who had a obvious head injury and one eye looked like A and the other eye looked like C. Okay. And it wasn't an eye injury, it was a brain injury. So that's another thing that it will help us identify. And later on in the semester, when we talk about concussion, we will end up getting and talking about the 12 cranial nerves and what nerves we're assessing when we're doing that. If there is no accommodation, we're worried about brain injury or alcohol or drug poisoning. And just know that the pupil response is much more important than the size. Okay. Movement. So another thing that we're worried about when we're, going out to a patient and can kind of be checking these things is what body parts are moving. Some people flail around and they're punching the ground and you don't really know what's going on. Others, it worries me when they're still. Okay, when they're completely still, it's even worse when you get to them and they're sawing logs, which means, they're unresponsive or they're unconscious. So inability to move, we're worried about a serious brain injury or central nervous system deficiency that is affecting the motor control. We are also potential worried about spine injury, below the neck that could compromise the function of the limbs. So if there is a neck injury, we run the risk of anything distal from the neck not being able to work. Okay, so with the neck down, that is quadriplegia, quad meaning four. And then if you're in the thoracic or lumbar area and have a spinal injury, more than likely you run the risk of being paraplegic, which para meaning two. So from whatever that vertebrae is down. Okay. Hemiplegia is the inability to move one side. And usually that's going to be indicative of brain trauma or stroke. Stroke will affect usually one side of the brain, will affect the opposite side of the body. Okay, now we're getting into the musculoskeletal assessment. Okay, we need to make sure we're using a logical process to evaluate. So there's not one specific right way to do it, and I'm going to talk about two different ones, but there needs to be a method to the madness. If you don't have a process and happen to jump around, which I will admit, early on in my career, I would go through things and I'd be like, oh, I forgot this special test. Let me add this. Once you get your, pattern down or your process down, stick to it. That way it will help ensure consistency and make sure that you don't miss anything. MOI stands for mechanism of injury. Mechanism of injury. And basically that's just the fancy way of saying what happened. Okay, so even if I saw what happened, I'm still going to ask because the athlete or the patient might have some good insights on what's going on or things that maybe I didn't see. Okay, so still ask what happened. It's helpful when they tell you. Other times, I don't know. There's other times where they come in, I don't know, it's been going on for like 3 months. Okay. If there is an acute injury, we always want to, and even chronic, but we want to ask what happened. And then the two different ways for the musculoskeletal assessment is going to be HOPS or SOAP. And normally I would write this down when I send this video out to you guys in the email. I will write out HOPS and SOAP. HOPS stands for history, observation, palpation, special tests. Okay, so, and some people do the HOPS method, other people use the SOAP method. I will tell you more in the medical field, we will write SOAP notes, of all different healthcare professions. There's not a right or wrong way. You should be able to identify both of these acronyms. SOAP stands for subjective, objective, assessment, and plan. And I'm going to get into each of those. They're very, very similar. Okay, so we'll go with HOPS first. HOPS, history. It's basically you getting a history, you asking them questions and getting any information that they can have. So think of any type of question that you can ask them. What happened? Where does it hurt? On a scale of 1 to 10, what type of pain is it? Did you hear anything? Has this ever happened before? What have you done for it? And then when we get into each of the individual body parts, I will go more in depth on anything that might be specific to that particular body part. So history is you asking questions. O on this one is observation, which is exactly what it sounds like. You are observing what's going on. It's easy. If it's an extremity, we want to make sure we're comparing bilateral. And in that observation, we're noting if there's any swelling, any deformity, look for scars, any type of discoloration, anything like that. So you're observing. And once you get better at this, you might be kind of doing this at the same time. So I know when I'm walking quickly out to the patient, I'm already observing what body position that they're in, what their reaction is. Okay. P in HOPS is palpation. Palpation is basically the medical terminology for touching. Okay. And it's not just touching, it's touching with a purpose. Usually I will ask them as part of the history, use one hand and use one hand and show me where it hurts, or one finger and show me where it hurts. I would love if they just did this. more than likely they'll do this. Okay, which, okay, that narrows it down. It tells me it's the left shoulder, but I'm trying to figure out structurally what to kind of think of as far as what structures might be involved. So when they do this, when I start palpating, if they, I try and find out what hurts worse, does A or B, and kind of figure that out. If they're one of the ones that, nope, it hurts right here, I'm not going to point right there, I'm not going to palpate right there to start off, because they're going to light up. Everything's going to be guarded, and they're going to be like, this lady is crazy and she's hurting me. So I'll start around where it hurts and then go towards where it hurts. That way I get a good read on what's going on. And then S is special tests. Okay, so with special tests, we will get into it further with the individual body parts, but special tests are individualized to those body parts, and it's something that we are stressing to see if there is laxity or movement where there shouldn't be movement, or tightness when there shouldn't be tightness. Okay. History, observation, palpation, special tests. Now going over to SOAP. SOAP, the S stands for subjective. Subjective. It's very similar to history. Subjective basically is everything that the patient tells you. It helps when you're asking them questions, so that's why I kind of give you both the HOPS and the SOAP method. Subjective is everything that the patient tells you. Objective, so O in HOPS is observation. O in SOAP is objective. So subjective, objective. Objective is everything that you find. Objective should be the same regardless of if I'm the clinician evaluating it, or if another athletic trainer is, or if doctors doing it. We should get pretty much the same objectives from that, where you can get measuring tape and identify what how much more swelling is on the injured side than the uninjured side. You would use a goniometer to figure out what exactly the range of motion is. Okay, so objective is everything that you find. You will also note discoloration, deformity, so that's why I say it's similar to observation. So subjective, objective. A stands for assessment. The assessment is not your clinical diagnosis, but what you think is going on. Now remember, the athletic trainers can't give a clinical diagnosis. They can give their differential diagnosis and go from there. And then P in SOAP is plan. What are we going to do to get this patient better to either their activities of daily living or to get back out to their sport? Okay. Going on to assessment decisions. So when we are figuring out what's going on, we want to see the seriousness of the injury, what type of first aid, or if we need to immobilize it, meaning splinting, and we will do a splinting lab. Excuse me. See if there's a need for immediate referral, and take into consideration, is this something that is life-threatening that maybe we need to transport them via ambulance, or is it something that we can make an appointment for tomorrow? So it depends on the situation. And then 4 is type of transportation. I will tell you, we cannot transport any of the patients with our personal car. Usually the type of transportation is stereotypically going to be from the field to either the sideline, and we might do a 2-person assist, 2-person carry, which we'll talk about, or it can be on the gator or a golf cart to either the athletic training room or to a vehicle to get them to where, the hospital where they need to go. So all of this information needs to be done in the evaluation, and a decision needs to be made. We always need to document to make sure we've identified what's going on and what our initial findings are, because often maybe the swelling is set in and you can say, oh, well, when I first saw it, this happened, or I had, this type of laxity. Immediate treatment. So with immediate treatment, you guys have probably heard about RICE, which is an acronym, stands for rest, ice, compression, and elevation. I'm trying to I just took a continuing education course and I took a screenshot of it because I like this. And it's something that I think we're going to be changing. Rice is always kind of the tried and true, where we're resting it, we are putting ice on it for 20 minutes at a time. We can be compressing it, whether it's with an ACE wrap or whatever, and then elevating. We want to make sure we're elevating above the heart so that, we can minimize swelling. The other acronym that I've heard of, either PRICE, which is just rice, but with a P in front of it, which is prevention or protection. But one that I hadn't heard in a really long time, and it's starting to get more and more popular again, is the acronym POLICE. POLICE. And that acronym is going to stand for Protection, Optimal Loading, OL, Ice, Compression, and Elevation. So the ICE part, ICE, is still similar. Instead of the rest, we're talking about protection and optimal loading. So letting you guys know that. Splinting. When we are splinting a patient, there are different methods, okay? There are different types of splint. I want to make sure, and I don't see that I have it on here, but you guys should note CSM. C stands for circulation, S stands for sensation, and M stands for motor, okay? So circulation, sensation, and motor. So usually in the medical world, we talk about CSM or CMS, just different order. I'm not too worried about the order, but I'm worried more so if we check CSM. Another thing that I have brought to the attention of my students is you can also use the acronym PMS, and I know everybody jokes about it, and I'm going to flat out say it in here. When I ask you the question about what does CSM or PMS stand for, there's always at least one in every class, even though I say it. When I'm asking about PMS, I am not asking about premenstrual syndrome. PMS is going to be very similar to CSM. P stands for pulse, so very similar to circulation. So when we're checking for pulse, again, we've already talked about the carotid pulse, the radial pulse. If it's lower extremity, you don't know the lower extremity pulses, or if the upper extremity, you can check what's called cap refill or capillary refill. So what that is you're squeezing the finger and you're releasing, and within 2 seconds, it should go back to the normal color. Mental note, if you're in a cold environment, it's going to take a little bit longer. Don't automatically think, oh, they're going into shock or they're not perfusing like they need to. It's just because it's cold outside. So take note of the atmosphere. Okay, so CSM, circulation, sensation, motor. PMS, pulse, motor, sensation. So the motor and sensation are the same on both of those acronyms. So that hopefully will kind of help you. With that, we're checking motor. So I would have them wiggle their fingers. If we're worried about, so down here in C, if we are worried about them, this one looks potentially like it is a wrist and they have splinted the wrist. I don't know, this is in your book, but we're going to check CSM both before and after we splint. So on any of these, I would check distally, cap refill, or a pulse, distal from further away from the body than where the injury is. I would have them move their fingers or move their extremities. If it's lower extremity, no, you don't necessarily have to take off their shoes. Put your hands over their toe box and tell them to wiggle their toes, whether it's cleats or, tennis shoes. So that's motor. And then sensation. Sensation would be, what finger am I touching? I don't want them to look at it. So if they're looking, that's cheating. Okay. So when they're not looking or not looking directly at it, ask them, what finger am I touching? Same thing with the shoe. Even if they have the shoe or cleat on, I stereotypically will do pinky toe or big toe because I'm afraid, what if I am, touching the wrong toe and then I, mess up. So when we're splinting, we want to make sure we check CSM both before and after we splint. Okay. And these are different types of splint. I have a typo right here. There's not supposed to be a U. Oh wow, I didn't think I could do that right here. But with vacuum splint, that's here, right here with A. We are using, and it's so much easier if I can show it to you guys, but it basically is a, not plastic, but a material that can be cleaned in case there is an opened wound. With that, we are, and all over it says do not cut, and there are paramedics or EMTs who aren't used to this and will still cut it, so that's why I know what it looks like inside. Inside, it looks like a whole bunch of popcorn peanuts, but those popcorn peanuts are smaller than the size of a pea. Okay. And what this kind of bike pump looks like is it's actually sucking the air out. So any place that I've been, stereotypically the high schools hadn't had it before, the very first thing that I purchase is a vacuum splint. So the red bag, 3 of these splints, and then that air sucky thingy outy. I know I don't really have a good terminology for that. I call it the bike pump, but I know it's not called that either. Is about $600. So yes, it's costly, but that will last you forever. Okay. I just bought 2 more, not just, now it's been 2 or 3 years, but with the explosion, our other ones had gotten damaged. I love vacuum splints because we can send the athlete or the patient with this splint on. So, whatever we're splinting is immobilized. They can actually x-ray through it. There's no metal on here, so they can actually leave it on. Kind of a sad or horror story. One of the schools that I was at, the very last 30 seconds of the game, one of my linemen got hit and had what's called a tib-fib fracture. So tibia, fibula. So both bones of the lower leg. Thankfully, it wasn't coming out, but we vacuum splinted him and transported him via ambulance because he was in a lot of pain and they needed to push pain meds. And after, literally, there's only 30 seconds left. We ended up going after the game, getting everybody ice and leaving fairly quickly so me and the other athletic trainer could take the van to the hospital to see, what's going on with that patient. Well, by the time we had gotten there, they were just getting him in to get an x-ray, and they had taken this splint off. And, it's Velcro, so you don't really need, to send the pump with them. I'd prefer if they didn't cut it because then you can reuse it, but that's a whole nother issue. But they had actually taken the splint off and were moving his leg on to go get x-rays. So they were setting it down, and the poor kid, I saw when the person was holding him and to put him on there, I saw his whole leg shift. So kind of like where the knee bends, but it was in the middle of his low leg. So that's why I'm a huge advocate for these. It's not like the everyday person would be able to use them. It's, specifically, for, I would say, sports. I know a lot of EMTs and paramedics will not use it because they don't have it because of the cost. And now with COVID, I'm sure there's other issues with that. But it is able to be cleaned. More often than not, we people and more of the average layperson might be using this down here with C. This is called a SAM splint. It's something that we will also be using. You can mold it and form it, which I really, really like. Again, with all of these, we want to make sure we're checking CSM, PMS before and after we splint. The main reason is if we splint and all of a sudden they no longer have that, or one of them, we're worried that something that we did with the splint has caused that. So that's why we check before and after. Over here, top right, is an air splint. Nobody uses those anymore, but it's in the book, so I have to kind of talk to you guys about it. And it looks, it's kind of self-explanatory. What that gentleman is doing is actually blowing air into it to cause a splint. The reason we don't use it anymore is because what if there is an open wound? What if, and blowing air onto it is basically like blowing a balloon around it, and might not necessarily keep it splinted because the air could be pushing on the injured part and causing them more pain, and we don't want more pain. And then bottom right is going to be a traction splint, which is for long bones, and really you only see those on ambulance rigs. So I wouldn't worry too much about those. In all honesty, I've only used it once in, almost 20 years. So just note that they do have those. And then the other thing that I have on here is cardboard splint. Whenever you're in a bind, utilize whatever you have. I have an athletic training friend. She was the first athletic trainer at the school. First game is freshman football on a Thursday, and ended up having a radius and ulna fracture forearm fracture of one of her student athletes, and she didn't have anything. She didn't have SAM splints or vacuum splints. She was brand new. She had put in her order, but again, it was still new. She was inventive and went to the snack bar because she knew they sold pizza, and pizza comes usually in cardboard pizza boxes. So with that, she fashioned a splint and sent him with his mom to go get x-rays, and the kid later on reported, "Man, I was so hungry, I kept smelling pizza, but they told me I couldn't eat anything." So utilize what you have. What was it? The middle of the night, my husband had fallen and, thought had fractured his wrist. It's not like I probably should have a SAM splint, and I might have had one in the trunk of my car or something, but it was 3 a.m. I wasn't thinking. And so I actually used a Capri Sun cardboard box. And I had, because we have, tape, and this is actually called PowerFlex in the house, where it doesn't stick to your skin, it sticks to itself. So when you donate blood, that stuff. So I used that to wrap it on him, and he wasn't in, a ton of pain, but we waited until doctors opened up and went and got an x-ray. He could have waited or gone to the emergency room, but his pain level wasn't that much. So that's why kind of utilize what you have. When we are splinting, we want to make sure that we splint proximal and distal to the injury. So if we're worried that, my forearm is fractured, I want to make sure I splint proximal, so the elbow, and distal to the injury, my wrist. Now, if it's my wrist that's dislocated, I want to make sure I'm splinting the bones that are proximal and distal. So I want to make sure I'm splinting the forearm and the metacarpals for a dislocated wrist. So again, proximal and distal of whatever the injury is. If it happens to be a joint, we're making sure that the bones proximal and distal are splinted. If we're splinting bones, we want to make sure the joints proximal and distal are splinted. Okay, equipment considerations. So there, we know we have a ton of different equipment, and depending on what sports you work with, we want you to be familiar with that equipment. We will have an equipment fitting and removal lab. I'm figuring out how to make that virtual, so stay tuned. With this, I want you to note on the left-hand side, it actually has the the old helmets, but we still have a ton of people who have the old helmets. We're fortunate at MJC that most of all of our helmets, actually we all have the SpeedFlex helmets, but instead of basically the screwdriver, it looks like, and I don't think I have a picture, but it looks almost like a target symbol, like the circle with a dot in it. But this dot, even if you don't have the correct tools, if you have, and usually I have a pen in my hair, if you have the pen, a ballpoint pen, not a marker, all you would have to do is hit that, and there's an automatic release. Now with these, there's a couple of different ways where we can remove. And when I say cutting or removing the face mask, I'm not talking about the white metal part. When we're talking about cutting the face mask, we're talking about this plastic kind of clear piece. Same thing over here, plastic kind of clear piece. Because what we're doing with that is making sure that even if we're keeping the helmet and shoulder pads on, that we have access to their airway. So they may have all their ABCs, but maybe en route, they lose them. We need to be able to perform, the ambulance, paramedics, EMTs need to be able to perform CPR. And if they don't have access to their airway, that's going to be a huge no-no. So When we do equipment removal, if we're removing the helmet, we're also removing the shoulder pads, because shoulder pads give us an additional girth. The helmet gives us an additional girth. If, they're lying down supine, so looking up, if we were to take that helmet off, they're going to extend their neck. And the whole reason we're spine boarding them is to minimize or reduce movement of the spine and of the vertebrae. On the right-hand side, it shows us different ways to remove equipment. Upper left hand is an battery-operated screwdriver. It's much more efficient. I always have a handheld one. One of my biggest fears is I'm not going to remember to charge it, or it's been sitting in there too long, and then heaven forbid I have to use it, and now I'm using, it not how it's supposed to be. So now it's cumbersome and potentially might have additional movement of the patient. The other two, one's called Trainer's Angels. The other one is FMX3. And those are just really sharp things to be able to cut the helmet off. Not cut the helmet off. Cut the clear plastic things for the helmet to take it off. Okay, now moving and transporting an injured patient. So first we need to make sure that we've done the primary survey. Okay, so they have their ABCs, there's no profuse bleeding, there's no shock. The next, we want to make sure that there's no fractures or dislocations. If there is, we need to splint them. If not, and even if we have splinted them, we still might be able to do some of these other handling techniques. We need to make sure that we practice these, because there's absolutely no reason for poor handling. There could potentially be additional equipment required, and we'll go over that when we talk about spine boarding, which is the very next one. Okay, spine boarding, and I will have videos for you when we do the spine boarding lab. This is kind of explaining to you what we're doing. Now remember, if an athlete is unconscious, we're automatically going to hold inline spine mobilization. Hopefully they become conscious and can answer questions. If not, we are definitely still going to spine board them. Again, it also depends on what county you're in and what the protocols are. So that's why I make sure I talk with the ambulance prior to games, so we're not having this conversation right above them. So over on the left-hand side, this person is holding inline spine mobilization. There's two different techniques. One of them is holding the helmet. I want to make sure we don't have our hands over the ear holes, because it's going to make it more difficult for them to be able to hear and listen. The other one, which is a lot more supportive, is you're actually grabbing their shoulder pads or grabbing their shoulders. I don't know why I couldn't think of that word, but you're grabbing their shoulders and using your forearms to kind of splint. I have little baby hands, little baby forearms, so that I usually do the top method as opposed to the lower method. But to each his own. There's not a right or wrong way. There is a wrong way. We don't want to have any type of movement, okay? And then this picture over here is showing that we have at least 7 people to be able to do this, okay? And I will have videos. I already have them pulled, but that's for a later time. So the person at the head usually is going to be the person who has the most experience, and they are the person in charge. Sometimes it happens to be the person that gets there first. Last football season, so last fall, we had a Fresno City kid that happened to go down closer on the numbers on my sideline. I was there first. He was sawing logs. He was lying prone, so face down. I had already put my hands in position because I knew when we rolled him, you don't want to roll him over his face. So I put my hands in position. Because if you just automatically go and he's upside down, when you log roll him, now you have to hold your hands like that, and it's all uncomfortable. So it's easier if you hold him correctly. The person at the head needs to take charge, needs to be assertive, and you will talk to everybody else. I know and have a really good relationship with all of the other athletic trainers, specifically within our league. And They take care of our athletes when our athletes travel to them. Same thing for when their athletes travel to us. With football, we travel just because of the sheer number. But I still, even though it was their athlete, I still held inline spine mobilization and I was in charge just because we don't want any additional movement. We did have the ambulance people come over with their spine board, and basically the person at the head is going to say, okay, even if you don't know their names, you're going to take the upper torso, you'll take the lower torso, you'll take the legs. Somebody is going to have the board. So, in all honesty, this guy might have potentially been fine with 5 or 4 people. Some guys that are huge linemen, a couple years ago, are huge Samoan guys but dang near 7 feet tall. When we rolled him on, his feet were still hanging off, which the feet are fine. We're worried about the spine and not having the spine move. And I know coach was a little worried with that. He's like, hey, we can have some football players come and lift. Actually, coach, we're fine. We do have enough people. There is a method to the madness, and I don't want to run the risk of somebody doing it improperly or wrong. Okay, so the person at the head, on the count of 3, we're going to roll them up to their side. 1, 2, 3. And the person with the board, I've practiced this with our athletic training students repeatedly. So, there will be a video, so it's not just me doing stuff with my hands. You're not getting a whole lot out of that, so I will move on. Ambulatory aid. The far right is a chair. We have one. I honestly never bring it out except to show in class, because in all honesty, with ambulatory aid, we're going to do on the left-hand side either the 2-person assist, which is the far left, where 2 people, and it's going to be so much easier if they are the same height, which, never fails. During basketball, I just grab one of the other basketball athletes, because nobody's ever as short as me, and say, hey, help them off the field or off the court. And you can instruct them on where their hand placement is and what to do. But you guys can kind of see the athlete is using both people as a crutch and has his hands around them. The people have one hand on their hand, and what you don't see is in the back, their arms are crisscrossed. I would prefer, and I know I have little baby arms, but I would prefer if you're actually grabbing the opposite side and we're grabbing clothes and body. Okay. Same exact hand placement on the upper arm. The other arm, instead of holding their hand, you and the other person are going to lock arms like this behind the person's knees, and you're going to kind of pick them up and carry them like a princess. Let me tell you, most athletes don't like being called princess. So, and then I think we only have a couple of slides left, guys. So, proper fit and use of crutch or cane. Okay, so getting them off the sidelines is fine and dandy, whether it's 2-person assist, 2-person carry. 2-person assist you can do, let me go back one. 2-person assist you can do even if they can put a little bit of weight on it, or if one leg is completely non-weight bearing. Okay, so with that non-weight bearing leg, they will just have that lifted up. If for whatever reason they can't, or they're hopping, or you're worried about them getting injured further, we would do the 2-person carry. Okay, little old me can still do a 2-person carry, on a huge lineman. I'm not, extremely strong, but when you interlock your arms, it definitely will help. But now that we've gotten them to the sideline, if they still can't walk, we need to either give them a cane or a crutch. More often than not, we're giving them crutches. So anytime that the lower extremity has to be non-weight bearing. So we need to make sure that we fit it properly. And I will flat out tell you guys, you will need to know how to fit for crutch fitting. And part of that is, and it drives me crazy, and I know it happens, in doctors' offices and in hospitals, because I see it, around our campus, or sometimes our student athletes come into the AT center and it's like, whoa, let me fix that. Okay, because a lot of times what people say is, how tall are you? Oh, I'm 5'1". And they'll go to the crutch and pop to 5'1" and say, here, have at it. Okay, that's not always the case. Some people have bigger torsos or longer legs, so we have different body shapes. So in order to fit for crutches, we need to make sure that the athlete is in flat shoes, no heels or wedges. That's just going to be a whole hot mess, which, believe it or not, I've had athletes in heels and wedges. Make sure the bottom of the crutch is placed about 6 inches from the outside, the lateral aspect of the shoe, and about 2 inches in front. Okay. So with that placement of the crutch underneath the axilla, so underneath the armpit, they should have about they should have about 2 to 3 finger widths, or about 1 inch underneath the fold of the axilla. Okay. I usually do 3 because I have little baby fingers, but what we're doing is the top of the crutch. Oh, that's not a good thing. This is clear, but anyways, the top of the crutch is going to go underneath the shoulder, and we're looking for 2 or 3 finger widths. You don't want less than that, because if it's less than that, and usually athletes and anybody tends to lean on the crutches anyways, so when they lean on the crutches, they're occluding or putting more pressure on the brachial plexus, and they might get numbness and tingling. Okay, so we don't want anything less than 2 finger widths. We don't want anything more than about 3 finger widths, because if it's more, now they're actually having to use their muscle to ambulate and walk, and it's going to cause them, one, they're going to be super sore, but they're also going to be super tired and not wanting to go anywhere. Okay, so it's about 1 inch underneath the axilla, and then also the hand placement of where the handles are on the crutches. So the handles should not be straight down. If you're doing straight down, they're not using any muscle. There should be about a 30-degree bend in the elbow to make sure that it fits right. Okay. And then if there happens to be a cane, I've never given a cane to anybody, but if there happens to be one, it should be at the same height as the greater trochanter of their femur. Okay. So basically at the ball part of the ball and socket of the hip, it should be that height. Also, when you're walking with a cane, the cane should be on the opposite side. So I like the show, I haven't seen it forever, but I like the show House MD, but he walks completely wrong with that cane. And actually has caused him ailments in real life because he does walk wrong with that. So I do want to make a mental note. So for proper crutch fitting, you should know that it's about 1 inch below the armpit, and your elbow should be bent at about 30 degrees. All right, that's all I have for now. I wanted to make sure that I got this to you guys. I apologize for not being there today, and but I guess on a positive note, you can watch this anytime prior to Wednesday's class. We will be meeting Wednesday at 9:35, and I am going to figure out if we can do Jeopardy, because I have not figured that out yet. I apologize. If not, I will at least log in. You can ask me questions. There is the syllabus. There is the study guide for our exam 1, which is going to be due next Thursday, September 17th by midnight. So make sure that you have that done. The exam code, I don't even have this pulled up. I will send with the email later on. I highly recommend you finishing this before taking the exam, and if at all possible, let's wait until Wednesday, where maybe we can even do the Jeopardy game, or at least ask questions. Have a good one. I appreciate you guys allowing me to send you this video. If you have questions, email me, and I will get back to you as soon as possible. Thank you, and have a good one.